Good evening.
The topic for today is going to be on intra-aortic balloon pump. To start with an introduction, so this is the most commonly used circulatory assist device, augmenting the myocardial perfusion. And this consists of a double balloon catheter placed in the descending thoracic aorta. The balloon is usually inflated using during the diastole, providing aortic counterpulsations. And this is the simplest and most readily available coronary artery device that's in the market. And the composition of the aortic balloon pump are it's a 25 sausage shaped balloon, which is made up of non-thrombogenic polyurethane, and it's mounted on a 90 centimeter vascular catheter, where one lumen is for distal aspiration and flushing, and as well as pressure monitoring. Also, the other lumen is for periodic delivery and removal of helium gas. So usually we use the helium gas for the balloon distension, and the volume of balloon is going to be around 30 to 50 ml. The indications of Iabp are in patients who are under cardiogenic shock. If we have a failure to wean these patients from cardiopulmonary bypass, and we can also use this for stabilization for emergent cardiac surgery, or which is delayed due to inoperability on these patients. Also, this can be used as a prophylactic use for coronary artery bypass patients with left main coronary artery disease and refractory heart failure patients who are waiting for a transplantation. The contraindications in these patients include to start with the absolute contraindications, wherein the patient has an ascending aortic dissection or aneurysm, severe calcific aorta, or a peripheral vascular diseases. And the relative contraindications would be a descending the descending aortic dissection or aneurysm, severe aortic regurgitation, irregular rhythm, sepsis, uncontrolled bleeding diastasis, irreversible brain damage, severe non-cardiogenic systemic diseases. And the advantages would be the balloon deflation during the ventricular systole, and it is going to reduce the LV afterload in these patients. It reduces the peak LV stress and the LV stroke work. Also, it reduces the myocardial oxygen demand in these patients. Also, it reduces mitral valve regurgitation. It also increases the left ventricular ejection in these patients. The balloon inflation during ventricular diastole increases the coronary perfusion pressure, augments coronary blood flow, and also it improves the myocardial oxygen delivery. The other effects of the Iabp are it augments cardiac output, reduces pulmonary capillary wedge pressure, and also relieves pulmonary congestion in patients. The procedure is usually these Iabp are inserted into the femoral artery, either percutaneously or via surgical exposure. It is done under a fluoroscopic guidance, and the length is usually calculated via the distance between the angle of Louis and the femoral artery. The final position of the balloon should be the distal tip should be at the below the left subclavian vein, and the proximal tip. Sorry, sir, pulmonary subclavian artery. Yeah, the below the left subclavian artery, and the proximal tip should lie just above the renal arteries. So the pumping is initiated and controlled by the console using an input from the ECG and aortic pressure. There are also other alternative approaches, which are through the subclavian artery, axillary artery, ascending aorta, and iliac artery. The timing and goal of inflation and deflation is the timing is to coincide with the aortic valve closure. It is inflated just prior to the dicrotic notch, and inflation is continued throughout the diastole. This produces a rapid rise in diastolic pressure, and this balloon inflation is going to create a constant increased pressure head between the Iabp balloon and the aortic valve. So this constant pressure head improves the coronary blood flow in these patients. So the deflation should always occur just at the end of diastole and immediately prior to the next systolic ejection. And deflation is going to reduce the afterload by reducing the aortic end diastolic pressure. This reduces the myocardial oxygen demand and also increases the cardiac output. The care there are a numerous care that has to be taken during the Iabp therapy. The patients should be nursed at a 45-degree head-end elevation. Chest radiograph should be obtained immediately after the Iabp procedures, and Harley documentation of bilateral distal pulses, also limb color, temperature, and a capillary refill Doppler evaluation has to be done. And frequent evaluation of pulse pressure waveform should be made. And the IABP should not be made standby for more than 20 minutes due to the risk of thrombus formation. And also daily there should be an evaluation for any site infection or site bleeding or hematoma, and limb movement and sensation. And there are some factors which is going to be influence the IABP therapy, which is the location should be immediately distal to the left subclavian artery. And the inflation volume should be 30 to 40 ml in adults, and the timing of the inflation and deflation. So weaning criteria in these patients are going to be usually these patients the weaning is going to be carried out over 6 to 12 hours. So which means two methods of IABP is going to be there, which is reducing the ratio of IABP inflation to the heart rate and reducing the volume of volume inflation, which is augmenting the strength of the balloon. So however, reduction of augmentation is never preferred due to the risk of thrombus formation. The balloon augmentation is reduced in steps, usually from 1:1 ratio to a counter pulsation of 1:2 and then 1:3. And the appropriate intervals are required between the reductions in to assess the hemodynamic and the neurological stability, also the cardiac and the oxygen delivery. There are complications associated with these IABP procedures, which is mainly the vascular complications, which is includes the lower ischemia, lower extremity ischemia, which is the most common complications which can occur in patients of 9 to 25% of the patients. Any arterial injuries due to perforation or dissection, aortic dissection, femoral artery thrombosis or pseudoaneurysms, peripheral embolization, and compartment syndromes. The other non-specific complications would be hemolysis, thrombocytopenia, infection, sepsis, hemorrhage, paraplegia, and coagulopathies. That's it, sir.
Very good. So, I don't know how many of you had a chance to witness this instrument being used and supported. Unless you have had a chance to work in the cardiac OT or ICU, normally the postgraduates learn about it from the theoretical aspect of it, but when ECMO is available, that will be the preferred method of resuscitation rather than going for IABP. Okay? And as you mentioned, IABP is a very short interval support, whereas ECMO can be there for a number of days also. So when facilities for ECMO are available, it will supersede the insertion of IABP for cardiac support. Is there any other expansion for this acronym IABP?
Intraarterial blood pressure monitoring, sir.
Yes, intraarterial blood pressure monitoring also was immediately recalled. So how did they remove this confusion? IABP can mean both intraarterial balloon pump as well as intraarterial blood pressure.
They changed it to invasive blood pressure monitoring, sir.
They just changed it to IBP.
IBP.
Instead of saying intra-arterial blood pressure, to remove this confusion of this acronym being mistaken for intra-arterial blood pressure also, they have now made it as IBP. Intra-arterial A is included in the I itself. Intra-arterial BP is called only IBP and not IABP. So all the points that you have mentioned are very, very well written and well presented. So I'll just share my